right, let's dive right into this explainer. We're going to trace the literal race against time when it comes to assessing and treating major burn injuries. When we talk about medical trauma, burn management is honestly one of the most intense, demanding, and incredibly time-sensitive areas of care out there. So today, we're focusing squarely on the core clinical skills, how to accurately describe the clinical features of burns, diagnose their exact type and extent, and then ultimately plan out the most appropriate life-saving treatments. We've got 5 main steps on the agenda today. We'll start with burn basics and first aid, then move into assessing the burn area, diagnosing burn depth, fluid resuscitation strategies, and we'll wrap up with surgical treatment and recovery. Let's just get right to it. Section 1, Burn Basics and First Aid. To kick off our patient journey, we really have to wrap our heads around one critical fact. A major burn is definitely not just a localized skin wound. It's so much more than what meets the eye. Extensive thermal damage actually acts as a massive systemic trauma. It totally alters the body's circulation and skyrockets infection risks. Basically, when tissue gets destroyed by heat, it triggers this immediate, overwhelming inflammatory cascade. Blood vessels become superpermeable, leaking fluid and proteins everywhere, which leads to massive swelling, and at the exact same time, the immune system takes a huge hit, leaving the patient incredibly vulnerable. But before you dive into treating the injury itself, you've got to put your detective hat on. You must screen for critical red flags, especially in vulnerable groups like kids or the elderly. I mean, if the story of how the burn happened just doesn't line up with the physical pattern on the skin, or if there's some strange delay in them seeking help, you absolutely have to be on high alert for the possibility of a non-accidental injury. And of course, just like with any major trauma, we lean right into our standard advanced trauma life support principles. You can't just get tunnel vision on the skin. You've got to secure that airway first, especially if they've inhaled smoke or hot gases. You manage their breathing, support circulation, and then finally get to step F, which is initiating that absolute life-saving fluid resuscitation. Which brings us to part 2, assessing the burn area. Once the patient is stabilized, the very first question the burn team has to answer is, okay, exactly how big is this burn? Sounds simple, right? But accurately calculating the total body surface area, or TBSA, is literally the foundation for everything we do next. Now, the classic rule of nines is a fantastic quick math tool for emergencies. A paramedic can look at a patient and rapidly estimate, 9% for an arm, 18% for a leg, and so on. But once that patient actually rolls through the doors of the burn unit, precision is everything. That's where the London Browder chart comes in. Developed way back in 1942, it lets clinicians carefully map out the exact surface area by breaking the body down into much finer, age-adjusted segments. And you really have to constantly adapt this assessment for pediatric patients because you simply cannot use adult math on a small child. Just think about it. An infant's head makes up about 18% of their total body surface area. That is double the adult proportion. So making these mathematical adjustments is absolutely vital to ensure kids get the exact right volume of fluids. All right, moving into part 3, diagnosing burn depth. So we're shifting gears from measuring the area of the burn to the actual clinical detective work of figuring out its depth. Because temperature and contact time dictate the level of tissue destruction, we have to look really closely at the wound's physical characteristics. Just notice the striking visual demarcation here between a superficial dermal burn and a much deeper wound right next to it. The superficial areas still retain some life and vascularity, right? But those deep dermal patches? That indicates severe destruction of the reticular dermis, meaning the sensation is reduced and the skin is just not going to blanch under pressure. Now for superficial partial thickness burns like this scald here, the dermis stays pink and moist, and if you apply pressure, you can physically see the active capillary return. That tells us the deeper layers of the skin are actually still alive. The damage didn't go any deeper than the papillary dermis. Obviously, these burns hurt like crazy because the nerve endings are perfectly intact, but physically speaking, they carry a highly optimistic prognosis. Let's fast forward and see what that recovery looks like. A superficial burn can heal up incredibly well within a couple of weeks, even if it takes a little longer for the normal pigment to return. If we give it proper supportive care, keeping it clean, managing the pain, the human body does a phenomenal job of re-epithelializing completely on its own without any need for surgery. To keep our treatment strategies straightforward, we basically sort all burns into 2 distinct paths. Group A, which heals on its own, and Group B, which absolutely requires surgical intervention. This sort of binary thinking helps the clinical team act fast and decisively. If a burn is leathery, has fixed staining, or is completely numb, which means those nerve endings are totally destroyed, it goes straight into Group B. We literally cannot wait around for those to heal on their own because they just end up causing terrible scarring and loss of function. We have to operate. On to part 4, fluid resuscitation strategies. Knowing that major burns create these massive fluid shifts, we have to jump in immediately to prevent severe shock. 15%. That is the critical threshold of total body surface area in adults, and it's 10% in children, where intravenous fluid resuscitation has to start immediately. If a patient crosses that line, giving them a glass of water isn't going to do a thing. They need calculated, massive IV fluid replacement starting from the exact minute the injury occurred, just to keep their organs perfused and alive. If we fail to manage their temperature and fluids, we risk throwing the patient into the lethal triad of hypothermia, acidosis, and coagulopathy, which just horribly spikes mortality rates. It's fascinating but honestly terrifying. Without intact skin, patients literally lose their ability to regulate body temperature. They get cold so fast, so we're pumping them full of warmed fluids and cranking up the heat in the room, and we're constantly watching their urine output, because if those kidneys are making urine, it's our absolute best sign that the fluids are successfully reaching the vital organs. Finally, part 5, surgical treatment and recovery. For those Group B burns we talked about earlier, we reach the climax of our treatment pathway, a highly orchestrated surgical intervention. This is where medical strategy meets technical precision. By stepping in early to excise a full-thickness burn, we're exploiting this critical window before severe vasodilation and immunocompromise really set in. In modern burn care, we do not wait around. By getting in there and removing the dead, burned tissue, the eschar, as soon as the patient is stable, we literally cut away the fuel for massive infection and stop that inflammatory cascade dead in its tracks. You can see here how the surgical team has precisely marked out the full-thickness eschar, practically drawing out their battle plan. They're preparing to use tumescence fluid to keep bleeding in check. Basically, tumescence involves injecting the super dilute solution of adrenaline right beneath the burn. It severely constricts the blood vessels, so when the surgeon actually starts cutting away the dead tissue, blood loss is drastically minimized. It's a total game changer. Once that excision is done, the transformation is just wild. All the damaged tissue has been shaved away down to viable, healthy fat, creating this clean bed that's totally prepped for primary intention healing. It's like a blank canvas. Reaching that healthy, punctate bleeding tissue is absolutely essential if we want to successfully rebuild the patient's skin and give them a real shot at returning to a normal life. And for the final step, a split skin autograft is applied immediately to provide stable coverage. This does something incredibly important. It helps reverse the patient's severe catabolic drive. By taking a thin layer of healthy skin from somewhere else on the patient's body and securing it over the newly cleaned wound bed, we're sealing the system. We stop the massive fluid loss, block bacteria from getting in, and essentially tell the patient's hyperactive metabolism, hey, it's okay, the emergency is finally under control. Now, as we look to the horizon of trauma care, it really makes you wonder, right? How soon will lab-grown autologous skin make today's incredible surgical feats look like ancient history? We're already edging into an era where we can take a tiny biopsy of a patient's healthy skin, grow massive sheets of it in a lab, and then graft it back onto them. It is an astounding leap forward. Just think about how that's going to revolutionize care for patients with 80 or 90% body surface area burns, where donor skin is practically non-existent. It leaves us with a genuinely exciting question about the absolute limits of human recovery. Anyway, thank you so much for joining me on this deep dive into burn management. Keep learning, keep questioning, and I'll catch you in the next explainer.